Well, good afternoon, everybody. This is Barry Wolf with Coronis Health. I'm the Senior Vice President. We're thrilled to be with you today, and we really want to thank you for taking time out of your day to come learn from some of the things that we've found very successful as we're now coming out of this post-pandemic era. It's definitely has been a stressful time, and we feel that we've really done a lot of good things for our customers, and we're excited to share some of those with you. Our hope today is that you'll be able to take a few nuggets back to your practice and learn some ways that you can help rebuild your practice. I certainly want to thank our partners with McKesson. Allison, thank you so much for setting this up. We're so excited to be with you today and share this message with many of your clients and many of the McKesson members. So with that, I want to talk about a couple learning objectives that we've outlined. As I said, we're going to focus primarily on all kinds of content that we've learned through many of our practices. At Coronis Health, we're a national revenue cycle management company. We work in almost every different specialty across the healthcare continuum. And so we have pulled together a panel of our deepest experts to really share with you how we can help you survive as you come into this new world. So some things that we'd love for you to consider today. Number one, looking at your systems. Are your systems that you have in your practice today, are they optimized for perfect performance, right? Coding is a huge issue, all right? There's so many things going on. We've got some amazing content that our folks are going to take you through and help you learn to see if your coding practices are up to date and with documentation, and so you're maximizing your reimbursements. A lot of our practices we hear from time to time are losing time and money because of inefficient systems, operations, inabilities to collect money, and so we're going to discuss some really data-driven trends that, again, we've discovered and we're hoping to pass on to you. All of these are going to be real-life examples of our clients and how we've really helped guide, coach, and mentor them through this process. And again, we're just so hopeful that you guys can take some of these learning nuggets away today. So we're going to skip the audience poll. I do want to take the time to introduce our team. Like I said, Coronis Health, it's a family organization here built on amazing experience. So with us today, some of the folks you're going to be hearing from, number one is Abby Arnold. Abby is our Vice President of Client Relations and Operations. You're also going to be hearing from Connor Doyle, who is the Director of our Analytics. Also today, we have Erin Walsh. She is the Director of our Client Partnerships, specializing in the FQHC world, and she's going to have amazing content to share. Also with us, Melody Jaju. Melody is the Director of Operations, is a certified coder, and has some amazing examples of what we've done with practices surrounding coding and helping them maximize. And then finally, we have Vince as a party. Vince is the Director of our Patient Revenue, and I know he's excited to share with you some of the key learnings on how we're driving amazing revenue into our practices from the patient side. So again, we have a team of experts here to share all kinds of real-time stories that we've been able to help with our practices. Again, just real quickly, we service at Coronis Health primary and specialty physicians, hospitals, surgery centers, FQHCs. We're strong in behavioral health, anesthesiology, pathology, and laboratory. So again, we have a very large, robust backbone in healthcare. And again, we're super excited to share all these key learnings with you guys today. So with that being said, I'm gonna kick the ball over to Connor Doyle, and he's going to take us into our first learning lesson on system optimizations. So Connor, would you please take it away?
Sure, thanks, Barry. Like Barry had said, we're going to start off with optimizing systems and operations. So if you want to go ahead and jump to the next slide, there we go. Obviously, the revenue cycle when it comes to healthcare is very complex. There's a lot of different moving parts and a lot of different facets involved, all of which either directly or indirectly impact the cash flow and the revenue for your practice. So one of the goals at Coronis is building that partnership and providing that analysis to you in order to review those operations, those systems that are in place, improve upon them, and make them more efficient. So we'll work with you to understand what's currently being done, what operations you currently have in place, and then from there, we aim to improve them. I'm going to go ahead and pass it over to Abby now, who is going to get us started on the next slide.
Awesome. Thank you, Connor. So just as Connor was saying, when you are looking at your systems, you want to understand how can you optimize your system best. So what does optimizing your system really mean, and how do you know if you're actually optimizing your system or not? So on the next two case studies, we're going to focus on different examples of groups that we've worked with that were in situations where they felt like they were optimizing their systems and kind of what we did when we came on board. So the first case study, it was with a group. They were a large paying group, and they really loved their EHR system, but they were less than satisfied with their practice management system. But they felt like because on the clinical side they were so satisfied with the EHR that they had to stay with that current practice management system. So when we began talking to them, we had discussed with them a couple options. Well, once we kind of got into their systems and we did a full task analysis on the onboarding process, we identified that the providers were very happy on the EHR. They loved the flow of the EHR. But then on the back end, the administrators just felt like they had no visibility on what was going on in the billing side. They didn't understand where the charges were going. They just did not have clear visibility of who was working on what and where they were working. And changing systems can be risky because when you change systems, you take a risk of possibly losing cash flow. So one of the things that when we came in, we had talked to them about how can we optimize, how can we have the best of both worlds, how can we still keep you on this EHR that all of your providers love, your front desk is more than happy with the scheduling system, but then how can we give you on the administrative side that visibility in order to understand, see your clean claims go out the door, understand where your money is going into your bank, and see reports that show trends month over month. So what we did is we took a look at their systems. Barry, if you will go to the next slide. And we ended up moving them from their PM system into a new PM system. And the way that we did that is we used an integration tool that helped us pull all of their charges and demographics out of their current EHR, and we built it out into our new PM system. With that, it's risky. Like I said earlier, you worry about your cash flow. So we had to make changes such as clearinghouse. We had to update their clearinghouse. We had to do completely new pay-to addresses. And they ended up switching a bank, so we had to reroute all of their money. We had to make sure that everything as far as all of the charges were being pulled over correctly. So there was a lot of different moving parts with this, and like I said earlier, it can be risky and it seems dangerous. However, with this practice and with what we're able to do, we were actually able to increase their overall monthly receipts by 10%. Because one, we gave them more visibility on their current charges and proper coding techniques. We were able to recode all of their ultrasounds. And then we also were able to implement audits for charge submission to make sure, based off of the schedule, we were pulling everything correctly over to our system, and we were able to increase their receipts by 10%. We also gave them access to a BI tool, so they were able to analyze their denials in order to drive change on the front end. And they also were able to start to see trends with their cash flow and when they would expect receipts. We implemented click-to-pay patient statements, and we increased their patient receivables in almost over 300%. And at the end of the day, because of the task analysis that we had done, we worked with them on, we worked on how to optimize their systems, and we worked with them as a partnership. There were no interruptions in receipts. Barry, if you'll go to the next slide. So the second case study, when we're talking about optimizing your systems, so when you're looking at how you know if your systems are being optimized and you're looking at internally what systems do you have put in place, with this particular group, they were a rural urgent care. They are in a location where everybody knows everybody. People working at the urgent care knew everybody in the community. It had that real community feel. And so they were very nervous because they had an in-house biller for over 20 years. And so what's that going to look like when you outsource to either an individual or a billing company, or you bring somebody else in new that doesn't understand your processes? That can be very scary, and it also can seem very risky because that individual or that company may not care, like that individual has been with you for over 20 years. And also it's kind of, if the system or process doesn't feel broken and you don't know any different, then why fix it? Well, when we started working with this group, and again, did a full task analysis with them, we went in, we've done on-site visits, we wanted to understand their systems, we wanted to understand their culture, because in order to be a partnership, we had to know what drove their business and kind of what their patients expected. So Barry, can you go to the next slide? So with that, what we ended up happening is in this specific practice, during COVID, they got hit really hard with COVID, and they almost had to close their doors because they weren't able to keep the staffing on the front end in order to do the patient registration process, et cetera. So what we did is when we came on board within 2 months of working with them, we did a full task analysis on all of their manual processes and what they were doing on a manual basis. And we were actually able to start implementing and utilizing their specific software in order to help with some of those manual tasks. And by doing that, one of the things that we implemented was the verification tool that was in the software already. So they had individuals that were verifying each service, and by us implementing this verification tool, it took away from somebody else having to do that manual work, and we were actually able to help them keep their doors open during a very stressful time. We've been able to help them move through an audit that they've been in for many years that they weren't able to get in, and it's because we were able to bring in expertise outside of, we know your system, we know your payers, and this is what we're able to do. And now I'm going to pass it back on to Connor to talk a little bit more about maximizing efficiency and what we can do with that.
Thanks, Abby. Yeah, so the next aspect we're going to jump into is coding. And coding obviously plays a very pivotal role in your practice and its success financially. So there's really no other industry out there that creates as many barriers to obtaining reimbursement for the services that you provide. If you think about it, payers are consistently changing their rules and making it more difficult to get reimbursed for what you have rendered. So Coronis aims to provide insight into your coding and use data analytics to actually spot trends, see what's going on, and understand what you're billing for, and then also at the same time showing you how you could create more revenue from providing the same services. So we can identify the work that's actually being done, ensure that documentation of the CPT codes reflect that, and then for the reimbursement being performed. So also understanding national coding changes and how those changes directly and indirectly can impact your business is extremely important. One of the key items that we've been working on is the 2021 coding changes, which for the E&M codes in 2020 compared to 2021, and how that can actually impact your revenue moving forward and then allow you to make business decisions proactively moving into the future. So we're going to move into a coding case study. I'm going to pass it along to Erin for the next slide.
Thank you, Connor. Yeah, so in addition to the annual coding updates, constant changes to the definition of the codes that we're using to bill for the services we're rendering, we also see payer mix changes and payer contract changes that impact coding and require a real careful analysis of the services we're rendering, how we're documenting them, how we're coding them, and how we're going to get claims paid. So an FQHC came to work with us with a real significant shift in their payer mix. They had more and more of their patients moving away from traditional Medicare towards Medicare Advantage. At the same time, these Medicare Advantage contracts, or excuse me, these Medicare Advantage payers were insisting this health center sign new contracts with really rigorous quality measures. These health centers are required to do care coordination, annual wellness visits, all sorts of new services that they may not have provided previously. So it's one thing to do the service. In order to get credit for it and to get paid for it, it's got to be documented and coded. Providers need to document and code the complexity of the visit to avoid losing any of these dollars. In the FQHC world, we run into some provider cultural barriers often. We know we get paid the same amount regardless of the work that we do for some of our major payers, most often Medicaid. We bill an encounter rate, we get paid an encounter rate. Coding doesn't matter. We also have providers who are very concerned about our patient population. In the FQHC world, we deal with and underinsured folks, and we have providers and community health center staff who are worried that if they overcode or if they code a complex service, a patient will get a bill they can't afford. We always tell our providers, code what you do and trust the slide, but that's easier said than done. So again, our message, record your complexity, capture those available dollars. You want to maximize your incentives. And in the Medicare PPS billing world, we also get a 1.3416 increase on our payment when we bill Medicare or Medicare Advantage plans that pay us PPS on these AWVs. Next slide, thank you. So as our client worked to roll out these services with great vigor, they were scheduling appointments, they were seeing patients, they were aiming to code what they did and document the service appropriately. We immediately put a hard stop in the system, so all of these appointment types would be reviewed by a certified coder. This certified coder was able to ensure the documentation supported the code, and the code that was selected was supported by documentation. That's a bidirectional relationship we need to always keep our eye on. We worked with their EHR managers to improve the templates. The templates that were originally created didn't make it easy for the providers to choose this type of code over a preventive code or an E&M code. We took both of those steps, the EHR optimization and the coding review, and we used it to create provider-specific feedback. So we have provider-specific templates. We have provider-specific training on coding. The real-time rejection and denial feedback for these services was shared with our client weekly, monthly, quarterly at provider meetings, just to get in front of them and to really point out the importance of the service you're providing to avoid leaving money on the table. So after this initial 12-month run of the AWV push on the clinical side, we took a look at our collection rate. We had improved from January to December in our overall dollars captured for these services. We were losing fewer dollars to denials. We were losing fewer dollars due to coding errors. And importantly for our clients, a little bit separate from the revenue cycle, but an important component of our clients' financials were those incentive dollars, those quality measures that they were able to hit because the annual wellness visits were documented, performed, and billed as needed. I think Melody is going to take us away.
Thank you, Erin. Our second coding case study consists of one of our clinical independent laboratory clients that vastly grew their lab revenue by adding COVID PCR testing during the COVID pandemic. While the additional revenue stream was an added bonus during a very difficult time, this, of course, also created a challenge for this client since the foundation of their business model became performing and billing for COVID testing with very limited test panels for toxicology, pathology, and genetic testing. Once the inevitable need for COVID testing would die down due to the upcoming implementation of COVID vaccinations, this raised the undeniable question of how this lab could sustain profitability and grow their business post the pandemic. Well, I'll tell you how we did it. In the summer of 2020, we understood that the COVID testing volume would not be at the current magnitude it was and reviewed the client's current payer mix and climax of testing and quickly identified that the revenue from this client's bill client for direct bill contracts with the state of Kentucky would decrease considerably by the end of the year and take a down because of the downturn in infectious rates in that state, as with the testing and billing for COVID tests for all government and commercial payers. Therefore, in order to sustain profitability and growth, we would need to add additional clinical laboratory services to this client's test menu. To do so, we helped this client in creating panels for toxicology, chemical, pathology, and genetic testing. We did this by having weekly meetings with their lab director and director of operations to discuss and analyze their current equipment, where there may be a need for additional equipment, what that cost would entail versus the average reimbursement rates per the payer mix within the current market. We reviewed their laboratory software systems and the capabilities to add additional testing and updated the interface with our billing software to accept additional codes for a streamlined approach. Reviewed and helped update their current requisition forms, provided education on clinical policies from payers nationwide, coding guidance by reviewing, of course, LCD and NCD guidelines for documented medically necessary diagnosis, CCI edits on bundling and medically unlikely edits on testing panels and testing models from our other lab clients successful in this space to provide much needed comparative guidance to obtain optimal revenue. I'm happy to report that as of today, this helped this client grow 3 times their pre-pandemic model to post-pandemic success. And with that, I'll send it right back to Vince Azzopardi, our Director of Patient Revenue with Maximizing Efficiency.
Thanks, Molly. Peter Drucker had a quote, "Efficiency is doing better what is already being done." Inefficient operations can greatly impact the success of your practice. Even though the work is being completed and money is coming in the door, we don't just stop there. Coronis strives to fully utilize systems and staff by continuously reviewing processes, workflows, and the potential automation of manual procedures. In the following case study, we're going to discuss more of the ways that we can maximize efficiency. I'm going to hand it over to Erin to speak a little bit more about this subject.
Thank you, Vince. So maximizing efficiency for our clients is all about looking at what processes are being performed manually and how can we utilize systems that are already in place, practice management system that exists, the clearinghouse that exists, to work smarter, not harder. So an FQHC came to us with an extremely manual Medicare PPS billing process. Medicare PPS billing in the FQHC world is tricky, to say the least. It is split billing. We bill Part A, we bill Part B. We're using a Part B benefit for the Part A service that we're billing. We need a qualifying visit. It needs to be with a specific core provider, et cetera, et cetera. This client came to us with staff members dedicated to manually reviewing each and every Medicare charge, and this client had a very high proportion of Medicare patients, to manually determine which of our PPS payment trigger codes would be added. These staff people would have to determine, is this new or established? Was this medical or behavioral health? Did the service actually qualify for PPS? We know we do a lot of services in our clinics that don't qualify for payment. That's why we get that elevated all-inclusive rate when they do qualify. So this process itself was time-consuming. It was muddy. It was wrought with errors by no fault of anyone's, but simply because when humans are making that judgment, the error rate is much higher than if a system is built to make those decisions for us. The client came to us with concerns about using the system in this way. If it's not broken, don't fix it, I think would be the best way to describe their attitude. Changing the system is risky. What if the system breaks? What if the system goes down and the staff people forget how to do this manually? We heard those concerns, we understood them, but we ultimately were able to describe our methodology, utilize our experience in this system, our experience in the FQHC world, our understanding of those Medicare guidelines, and really force the issue of utilizing the existing system, maximizing that functionality, getting away from manual processes, and really taking advantage of what's available within your host system. Barry, you can move. Thank you. So when they came to us, as I said, we took a look at their manual processes. This one jumped right out to us. None of our existing clients were utilizing this manual process. We had created similar processes in a handful of different practice management systems. The one good thing about Medicare is you know Medicare in all states. CMS is the same regardless of where you're billing for these services. We work directly with the customer and with the system host to create an environment of transparency where we all had the same end goal. We were all working towards the same optimization with the same priorities in mind. We were going to improve compliance. We were going to reduce charge lag. We were going to reduce average days to pay. These were all good things for all three of our organizations. So after some conversations with the group and some buy-in that we eventually received, we eliminated the need to manually review all these charges. So charges are now being processed and claims are submitted on a daily basis. They're no longer hitting a hard stop and having a charge entry staff person have to make human judgment or a decision based on what's present in the system. We had also reduced the manual payment and adjustment posting. So because of this manual process, we weren't able to post ERAs. We were not only manually handling charges, but when they came back as payments, we were manually handling those too. So we reduced the need to do that, and we are now nearly 100% auto post on Medicare for this client, which again, reduce your charge lag, reduce your days to pay, fewer days in AR, more cash in the door. What can go wrong? And I will, I think, hand it back over to Connor.
Yes, thanks, Erin. So the next case study that we're going to look at is a large multi-specialty provider office. They had more than 10 locations and 60-plus providers. So the multiple offices and the staff operating autonomously, they lacked consistent processes across the board. In addition to that, the fact that there was so many different specialties and different locations, it only added to the complexity of this practice's billing department. This resulted in issues like disparity in how you resolve claims for denials or how you collect front desk payments. All of that was a result of just lack of communication between the different offices. So this also resulted in a lack of unity relating to financials and no transparency within the organization to review their overall fiscal health, which resulted then in the lack to make decisions in a timely manner. They couldn't gain insight into what was going on or how their billing department was doing and what processes were potentially causing issues. And they were also using numerous systems. They were using, obviously an EMR, a PMS system, they had their clearinghouse, but none of these are really talking to each other. So this caused them to do manual labor by having to log into the clearinghouse and grab the different rejections or denials and then manually transpose them back to their practice management system in order to work those claims. So obviously, with that factor, you have a loss of productivity, increased labor costs, and you're also slowing down the payment cycle or the revenue cycle for the practice. They were very concerned about moving to an outsourcing company. They thought they were going to lose control. They wouldn't have the transparency that they currently believe they had. But like we just talked about, that transparency was already somewhat missing with their practice and how they were doing. So we kind of came in, and Barry, if you can roll to the next slide, we kind of came in and we've kind of talked about this already in doing the task analysis and reviewing what they're doing, how they're doing it, and how can we make it better. So we were able to partner with them to develop new coherent processes across all of their locations and then unify the operations as well. So this way, every single location is doing each aspect of the revenue cycle in the same way to an extent. One of the biggest struggles, like we had talked about, was the lack of interoperability between many of their systems and their clearinghouse. The lack of communication between the clearinghouse and the PMS system, like I had mentioned, was forcing redundant work. So one of the biggest goals that we aimed to do is we came in there and we created that full integration between the clearinghouse, the practice management system, and the EMR, which then allowed the 277 front-end rejections and the denials to automatically flow into the practice management system. And then from there, they could work claims quicker, get them out the door faster. It also resulted in additional transparency into financials, and then also using data analytics to analyze current denial trends from certain payers or certain specialties, wherever it may be, to then create new processes on the coding end, on the front end, to increase that efficiency even more so. So doing this whole process resulted in a myriad of different improvements, but the biggest ones being increased efficiency for the employees, increased turnaround time for claim submission, reduced denials, and increased cash flow. So it was a huge win for the practice, and we have kind of shown them that by having a partner, you're not going to lose that control. What it's going to gain is we're going to provide knowledge for you to help you improve the current process that you have in place. So with that being said, I'm going to pass it back to Melody to keep us going here.
Thank you, Connor. Our third case study on maximizing efficiency consists of a new client who came to us just a few months ago with their financials in the red and billing in complete crisis. The challenge was that in the heart of the pandemic, this client was performing thousands of COVID testing with telehealth visits and had a backlog of over 250,000 claims. This client was focused on the quality assurance of the COVID testing to maintain high levels of efficiency despite the volume of specimens tested, which is great from a clinical perspective. However, like most offices do have, this left the billing neglected and behind while the client was adhering to manual approach of physically entering all charges into their billing software from their LIS and manually posting all insurance payments. We were able to clear that backlog by using technology to completely automate the charge pass-through from their LIS or EMR to transpose thousands of claims at a time from Excel format into 837 files or electronic claims. Our offshore team working 24 hours a day, 5 days a week, a dedicated onshore onboarding team, as well as a focused onshore revenue cycle team with certified professional coders that specialize in coding and billing for COVID vaccinations, testing, and telehealth visits. On this next slide, Barry, we show how we cleared this backlog within 30 days by analyzing revenue cycle management at a 360 approach. What we did is we uploaded, scrubbed, and submitted all claims to the HRSA uninsured program, government and commercial payers, and began seeing payments within just 1 week of going live. We could quickly set up electronic fund transfers and electronic remittance devices for all insurance payments. We also provided coding and billing guidance to help capture additional revenue, performed E&M level audits on the televisits, and provided the necessary bandwidth with staffing to turn a very stressful situation into a very positive one. After just the first week of working with this new client, this group went ahead and provided much-needed bonuses to their staff due to the confidence they felt in their overall billing, as stated in this client's quote below. As of today, this client has recouped multi-millions in revenue and is now successfully billing and administrating thousands of COVID vaccinations. We are also assisting this client with staffing, laboratory compliance regulations, provided a customized reporting dashboard, coding guidance on expanding urgent care services and laboratory panels outside of COVID vaccinations and testing, of course, customized eligibility verification, and so on to ensure long-term growth and success, again, post the pandemic. Now back to Vince.
Thank you, Melanie. That's some valuable information you just added. Visibility and transparency on the next slide are the key factors in the following case studies we'll be going over next. By utilizing technology, Coronis brings visibility to trends, potential issues, and performance while being able to pinpoint specific data. We will also discuss patient collection. For as advanced as the medical industry has become, a recent census shows that 90% of organizations are still sending paper statements. With patient responsibility continue to grow year after year, Coronis is highly focused on optimizing revenue growth in this sector, which I'd like to further discuss on the next slide. There are many elements in the success of collecting patient balances, such as demographic and socioeconomic factors. However, utilizing technology, we can begin to even the playing field by reaching out to patients digitally and by building out specific patient notification rules. In this case study, we had a practice whose patient aging was steadily on the incline, previously using typical 30, 60, 90 paper statement cycle. Coronis altered the patient statement process by introducing a heavy e-notification billing cycle. By implementing this digital notification, we're able to reach out to patients immediately and more frequently, which resulted in getting the balances paid faster. This also added to bypass incorrect address demographics due to patients relocating or data capture errors. In the first week of going live with the software, we collected 62% of the average monthly patient receipts. Since introduction of the software, we've seen a growth rate of 200%, and the revenue has steadily increased. Not only are we increasing revenue, we're also saving on the manual intervention and the paper costs. On the next slide, Aaron will be following me with more information on the benefits of technology.
Thank you, Vince. Yeah, so the most critical part of managing any revenue cycle, or really any process, is understanding where are you, what is our current state of affairs, and where do we want to go. And from there, you develop that clear roadmap of, the path towards success. Knowing where our open AR lives, what payers is it outstanding with? Why was it denied or rejected? Who's working on it? Who's responsible for it? That's really critical for managing a revenue cycle with success, reducing days to pay, reducing days in AR. One FQHC came to us. Their AR was steadily increasing, 5 to 6 days a month. Their write-offs were increasing. They were losing claims to bad debt, insurance claims to bad debt. Their critical claims were being ignored. So high dollar, approaching filing limit, these claims simply were left untouched week after week, month after month, until they hit a point where they had to be adjusted as they were no longer collectible. Their staff were overwhelmed. Their staff didn't know where to begin. Their staff were facing a growing problem that just kept getting worse week after week. When the list is so long, where do we even begin? I think we can all appreciate that sentiment. When your to-do list is 5 pages long, it's difficult sometimes to identify which item is most important, which claim do we need to work first, which payer is most problematic in our revenue cycle. So the BI tool that Coronis Health utilizes provides an aggregate high-level view of our entire AR. It tells us where are our dollars sitting, at what stage in the revenue cycle are they? Have they been denied? Have they been rejected? Is someone working on them? When was the last time they were touched? Whose desk are they on right now? Who's responsible for resolving them? And really the goal of that tool is to identify these claims before they become past filing limit, before they become super critical, and really focusing on those high dollar, important claims, growing payers in our AR really helps us prioritize what we're doing. Next slide, please. Thank you. Again, so our tool is a workflow management tool. It allows us to pinpoint and prioritize those critical claims. We want our staff or the billing staff of our partner health centers to be working those first. We want to isolate claims that are actionable. We don't need staff or billing partners working items that were only recently submitted or aren't even close to a filing limit or haven't yet been denied or rejected. We want staff to be focusing on those claims that have been determined to be actionable and have been evaluated for criticality. So this health center came to us, again, they implemented this tool for a 12-month engagement. As we started working with them, we really quickly realized an increase in their average payment. So we were able to drive that 7% increase, again, our average payment, our blended encounter rate, capturing more dollars for every patient encounter, simply by managing our AR at that high level and by managing the work that our billing staff is doing. We also saw an 8% dip in our denial rate for this group. So this clinic was able to take the pointed feedback available in the dashboard reporting from our tool and resolve front desk issues, coding issues, identify provider credentialing challenges that were leading to lost AR. And most importantly, we reduced our paper EOBs by over 50%. In 2021, we want to be as automated as possible. We want to be as electronic as possible. Our tool quickly identifies and prioritizes those payers where we're still receiving either paper EOBs or paper checks and helps drive that ERA, EFT enrollment process, which is really critical to reducing your days to pay, improving your efficiency, and being able to capture dollars sooner through your revenue cycle. And I think probably what this client found most valuable of the BI tool was our ability to provide high-level dashboards. How many denials have we received versus how many charges have gone out the door? Is that trending up or down, and why? Of those denials for front-end reasons, why? What is the subcategory? Are we dealing with eligibility challenges? Do we have coordination of benefits issues? Are these denials focused from one particular site? Do we have a training need for front desk staff? Do we have a need to update our eligibility software, integrate our eligibility software, like one of the examples mentioned previously? And most importantly, trend this data over time, that roadmap to success. Are we moving in the right direction? Are we going in the direction we want? Where is our revenue cycle today versus where it was yesterday, and where do we want to be tomorrow? That's really the value of this workflow tool. And I think providing that visibility into your revenue cycle gives us the keys to success as far as managing from charge entry all the way to payment posting. And I think I'm going to pass it back to Barry. Yes.
Thank you, Erin. Appreciate it. So we're coming to the end of our presentation. Number one, we just hope that this information has been helpful, a ton of content and a myriad of opportunities for your practices to take with you and learn from some of the successes that we've been able to enjoy. One of the poll questions that we'd like to throw out is if you would like more information from Coronis about how we've helped these practices and maybe can help yours, just click on the poll that will be dropped here shortly by the moderator. And with that, I'm going to go ahead and pass the controls back to our moderator. Again, I want to thank everybody for joining us today. We really enjoyed this time, and we hope that the information was helpful. So thank you very much.
Thanks, Barry. Thanks so much, everybody, for all of that information. We do have a couple questions coming in, and I want to remind you, if you'd like to ask a question of the panel, go ahead and enter your question into the Q&A console and click Send to All Panelists. So the first question, I'd like to know if you have their industry or the average industry denial rate. They're wondering this for benchmarking purposes, and if you have an industry average for that.
I'm not sure if that question is coming for the FQHC industry, so I will take a stab there if my panelists colleagues are okay with that. I think it's a little bit of a tricky question because we need to, first of all, agree on the numerator and denominator of when we're calculating that rate. So probably 9 different ways to Sunday on how to actually determine your rate. But our software utilizes the number of instances, so that's either a paid or denied claim that came into our system, again, that BI tool, as the total, and then we put the number of denied instances to get that rate. So we aim for about 5 to 7%, again, depending on the client, depending on some of the issues that they may have going on in the system. Of course, you know, a provider credentialing challenge may cause us to need to bump that rate up. But when we use, again, in our system based on our methodology, we aim for about 5 to 7%, and that's denials. A claim acceptance rate, we'd like to be closer, again, on the rejection clearinghouse side, 98, 99%.
Great, thank you. And again, if you have any questions, just go ahead and enter them into the Q&A console. It's located in the bottom right-hand corner of your screen, and click Send to All Panelists. Next question is, you know, when you have things that you spoke about, like click to pay and things that, you know, are mostly, you know, talking about cell phones, how do you handle this with geriatric patients and that demographic of the population that may not have access to a cell phone?
Yes. So we've actually had some success by creating if-then type rules within our software, where if a patient is 70 years old or older, we'd actually drop that immediately through paper. However, what we also try to do is we work with our partnerships to make sure that we're getting, if patients have like a caregiver or a guarantor, we will send an e-notification to them because we still want to collect that way. We find it more efficient, obviously, collect more revenue in that way as well. We picked 70 at this point in time just because, speaking from experience, my father was in the 60s, and I'm pretty sure he's more active on his phone than I am at this point.
Great, thank you. So how long does it take for your team to do onboarding? How long is that process?
Yeah, so typically, like we were talking about, so when we are onboarding, that's when we are building that partnership. And so we want to do a task analysis from the point of when the patient calls the front desk and what that eligibility and verification process is, what that registration process is, all the way through to that patient phone call once they've received a patient statement and collecting those patient statements. So we look at every aspect that is part of the revenue cycle. And with that, we have a comprehensive document that we send to all practices. And as long as that we work together as a partnership and we are on the same page as far as gaining access, we can onboard most of our practices successfully within 2 weeks to 30 days. some of our larger practices who, if we're doing any sort of software change that may be kind of outside of the box, or a pay-to address change, or credentialing involved, different things like that, then it could be a little bit longer. But typically our standard for onboarding is we would like from the point of contract signed to onboarding to be 30 days. Rebecca or Allison, are there any other questions? I don't know if one of you guys were on mute and were asking additional questions.
Yes, that was me. I was on mute. I apologize.
No worries.
We do have a couple of questions coming in about getting a copy of the slides and the recording, and you will be getting that via email within 24 hours. You'll be getting a copy of both the recording and a PDF of the deck from today, so to answer those questions. The next question is about coding, and specifically they'd like to know how you would come in and analyze the coding at their facility.
I think this is kind of almost like a two-part question. From the standpoint of doing the analysis, we would obviously pull raw data from your system, and take that and start reviewing and analyzing it and breaking it down and looking at, where your trends are, looking at E&M bell curves, different things like that. From there, then someone like, I'll pass it over to Melody, a certified coder would kind of start doing reviews of the charts and whatnot.
Yeah, that's a great question. What we would do is we would take an overall analysis of the entire coding and, like Connor said, review the E&M codes audit, look in areas to see where else can we add additional coding for additional revenue, where are we missing out on, do we have cheat sheets on diagnosis that are documented and medically necessary for the LCDs and the NCDs, are we looking at all the CCI edits, are we looking at all of the areas for unbundling. So we want to make sure we look at a complete approach, see where we're missing out on additional revenue that we can add to your practice that is completely available for you. We just want to make sure that you have coding expertise to help you every step of the way. Thank you.
I have another question about benchmarks. What is the average accepted AR days between 0, 30, 60, and 90 days? Looking more in terms of percentages if possible. Are you able to answer that?
I can take a stab at it. So you're asking what percentage of your AR should be in those buckets. Is that correct?
Yeah.
Okay. Usually general rule of thumb is you want at least at a minimum 80% of your AR under 90 days. Obviously, the more under 90, the better. But when you're looking at the buckets of, 0 to 30, 30 to 60, so on and so forth, roughly, I would say about 65%, 70% or so should be in that 0 to 30. And then you're going to have, the remainder is kind of falling into those other buckets. Utilizing, the percentages there and then also tracking DRO or the days receivable outstanding, those two metrics, pretty much go hand in hand. So if your DRO is sitting right around 28 to 30 days, you usually would end up seeing a similar percentage in those buckets. So, about 60% in 30, 10% and, 5 and 5, and then the remaining 20% would fall in the over 90. But that's kind of general rule of thumb. Obviously, specialties and, patient makeup, payer mixes, those all have, different impacts on it. But I would say that's kind of what you should expect to see in a well-performing practice.
Great, thank you. Another question about, how do you go about doing that past analysis or the audit? How would that work? What do you do when you go in to make sure that people are using their systems efficiently? What does that process look like?
Yes, absolutely. So I'll take a stab at that one. That all takes place at the onboarding process. And so what we're looking at is we really want to understand your business and your culture. And so like I said, we will start from the point of, because that first point of contact when revenue cycle starts is when that patient first calls your practice to register to come see a provider. And so we're going to look at all the way from your front desk, what are the questions they're asking? We ask for your financial policy. We want to take a look at your registration paperwork. Are you getting copies of the front and back of your insurance cards? Where are those cards being stored? What are you looking at as far as insurance eligibility and verification? What's the frequency and cadence that you're checking your eligibility and verification? And then we go next step. So once the patient's registered, they're in the system, then what's it look like on the schedule? Once the provider steps in place and takes a look at the patient, how do they document? Where is their medical documentation stored? How are they managing submitting their codes, and what's the rules for your providers as far as how quickly they need to get their charges in the door, and how are you getting those charges? Are you still on paper, or are you using an EHR, but is your EHR not talking to your PM system? And so that kind of going from your EHR to your PM system is more of a manual process. So we go through that whole process with you, and then we'll take a look at what's your pay-to address. Do you have your enrollment set up? What are you getting as far as EFT and ERA, and is there a lot of paper that's coming in? One thing that we have done quite a bit pre-pandemic, but really during the pandemic and post-pandemic, where we're leaning is paper is our enemy. So we want as less paper as possible in all parts of the revenue cycle. So we're going to look at what is paper, what requires a human interaction in order to complete a task, or is your system able to do that for you? And then we'll take it then that next step further and take a look at when the claims are going out. So that one example where we were taking a look at the clearinghouse, when the clearinghouse wasn't talking to the PM system, for us that was an issue because we want things bi-directional. When you involve humans, it can start to get risky, and you always open it up for error. So we'll take a look at that, and then, like I said, that final step. So how are your patients being notified that they owe a bill? Are you collecting your copays and deductibles at time of service, or are you collecting them after the fact? And then how are you communicating to patients that they owe a bill, and then how do you collect that money? So we're, like I said, we're taking a look at every aspect of your revenue cycle to make sure that things are moving along efficiently, and then we like to do a deep dive and work as a partnership to be able to identify ways that we can really optimize those systems in order to improve your revenue.
Great. Thank you, Abby. All right, well, I don't see any more questions coming in at the moment. They're starting to slow down. So I am going to go ahead and make my closing comments and wrap things up by thanking everybody for attending today. Thank you again to our presenters from Coronis Health for sharing all of your expertise with us today. And as a reminder, you can find a list of all of our upcoming webinars on our website at mms.mckesson.com. Thank you, everybody, and have a great day.
And this does conclude today's event. You may now disconnect your lines.